Hi, this is Mitch Mitchell of TT Mitchell Consulting, and this is the second of the videos I'm doing talking about Charge Master. In this case, today I'm going to talk about pricing. And there's two different ways of initially looking at pricing. There's inpatient pricing and there's outpatient pricing. And I'm going to start off talking about inpatient pricing just because it's simple, it should get it out of the way, and I hope that it's easily understood. So, basic part of inpatient pricing, if hospitals are doing it the way that you hope that they are, is based off of one or two things. The first thing it's based off of is the hospital's costs. Now, putting together the costs of any business is not easy to do, and the same thing goes for hospitals. I mean, you have to, look at all the personnel that you have, you have to look at all the benefits, you have to look at things like your utilities, all that stuff, equipment, all of that stuff has to go into figuring out what your costs are. And that can be a heck of a job. I mean, it can just be astronomical. Yet you have to have some kind of idea of where all of that stuff comes in. The second thing you have to look at is what kind of reimbursement you get for the types of services your hospital provides. In the United States, hospitals are paid on what's known as a DRG, or diagnosis related grouping. What happens is that a person comes into the hospital and they give them an initial diagnosis, and then if they stay longer than a day, sometimes they stay less than that and they pass away, and that's a different kind of scenario. But in general, if they stay at least a day or other, a few more days, what happens is that there's all these different diagnoses that come up on a patient. Everything that this person has, whether it's something they had pre-existing, which could affect what they have now, or if it's just anything that is a complication or an addition to the reason that they're in the hospital, all of these things are coded by medical records and it's put into some kind of system. And I put it that way because there's multiple systems that they can put them into, and it does this number crunching thing and it comes out with a certain DRG. And then all the insurance companies will pay based on whatever DRG classification they come up in. By that, I mean Medicare has its own DRG payment, Medicaid has its own, different commercial insurances have their own, Blue Cross has their own. It's possible, well, actually, compensation and no fault, they all have different reimbursements for these diagnoses. Now, you have to make sure, if you're a hospital, that your room rate, which is charged daily, by the way, it's a daily per diem room rate. You need to make sure that whatever your room rate is going to be higher than what you're going to get paid on the DRG. And so, what you'll hear a lot of hospitals talk about these days is trying to make sure that patients don't stay beyond so many days. And you do that because the longer a patient stays, depending what their DRG is, you start to lose money. That's just how life goes. So, you're hoping that someone comes in and doesn't stay overly long, and that, when you discharge them, that you're going to make enough money so that you can continue to survive. Now, if someone comes in with a broken leg and they end up staying for a week, most probably the hospital is going to lose money if they were not able to get that person out sooner. At the same time, there will be certain charges that, in another vernacular, you would consider outpatient charges that you will add to the bill. But the overwhelming majority of those have to be included in the inpatient. So, as I mentioned, the broken leg, if you do something and now you send them to physical therapy, if you're able after a few days, you're going to add physical therapy charges to the bill, but it all gets caught up in the DRG. So, that's pricing for inpatient. Outpatient is kind of a different animal because it can be based on a host of things. And by the way, outpatient also considers doctors. You can still go off of costs for each one of the departments. It's, once again, complicated to do, but it can be done. So you can base it off of costs. You can base it off of what they call, in some areas like Medicare, it's called APC. And APC basically is a payment rate for different groups of outpatient services that you have. It can be based off of a fee schedule. Physicians will sometimes base things off of fee schedules that they'll get from these different insurance companies to tell them how much they're going to pay for all these different things. And in healthcare, things get marked up just like they do everywhere else you go. If you go to the grocery store, for instance, and you come across a dozen of eggs and they're charging you $1.50, well, you know that store didn't pay $1.50 to get those eggs. That store probably paid something like 60 or 70 cents. So they've marked it up at least 100% so they can make some money off the deal. That's just how life works. Well, the same kind of thing works for hospitals. If, for instance, if Blue Cross says that they will pay $100 for a certain service, then you're going to mark it up just a little bit. Now, does all of that, which is not paid by an insurance company, get passed on to, the patients? That isn't true across the board. For instance, if you happen to have Blue Cross and the physician you go to or the hospital you go to participates with that particular Blue Cross, most probably you either will have no payment whatsoever, or you might owe a $20 copay, or you just might owe 20%. It depends on what is in your contract that you have with the insurance company. Now, you look at things like supplies. Hopefully, if your hospital has any sense whatsoever, and I'm just saying that, I don't know for sure, but there's things that you see. Hopefully, they have a markup schedule, and it's based on how much the item is that they purchased. For instance, if you've got an item for less than $100, you might have a policy that says anything that's under $100, we mark up 100%. That's not so bad. If you get like a foam collar, for instance, and it costs $75, you mark it up $150, that's not so bad. However, if you have something that's already expensive, and I have seen this on occasion where there are hospitals that do cardiac cath, and you see that they've got pacemakers, and the pacemaker that they had to get is $5,000 or $10,000, and they mark that up 100%, well, now you have a problem. And I've seen hospitals that mark it up even more. You're never going to get that. It's going to be a major write-off. If the person is self-pay or has an insurance that the hospital doesn't participate with, it's even going to get worse. And it's pretty much, it's a waste of effort to put in that kind of price. But it's all about hospital policies. And as I said in the first video, if you happen to be in an area where costs are really high, large cities have really high costs, then your charges are going to be high. If you're in an area such as in a smaller area, small county, or a city of maybe 100,000 people or something like that, which doesn't sound small on the surface, but it pretty much is. And if you have a hospital like that, the costs are going to be more in line with the cost of living of your area. So you're probably not going to get beaten up as badly. And of course, the smaller the hospital, the better opportunity that you have. So, you have those kinds of costs. Now, one thing I know a lot of people fuss about is emergency room. I just want to throw this in there. An emergency room has different levels, and it has different levels based on both the severity of what it is you're in the emergency room for and the length of time. And most of the time, you base everything on severity. And you probably have, wondered, geez, why do emergency room bills cost so much? You want to know a reality? Most hospitals, almost every single hospital in the country, loses money on emergency room. They just do. Costs are high because you have so many people come in the emergency room who can't afford to pay the bill. So, just like in every other industry, everything goes higher, and therefore it's passed on to everyone else. And the other side of that is that if your emergency room bill came to $1,000, I'm just throwing out a number. If your emergency room bill came to $1,000, but the reason you were in the hospital is something that really didn't come to that kind of dollar amount, and say your patient has Medicare, what? Medicare is only going to pay a certain amount. Hospital has to write everything else off except for the amount that you actually owe, and it gets passed on. So, emergency rooms are just that way. You get, it costs a lot of money. There's federal regulations that say you have to treat certain people. And it's just one of those areas, since it loses money, that costs can be high. So it's not really the hospital's fault all the time. Are there hospitals that pretty much have prices that are way out of whack? Absolutely. But is it an across-the-board thing? No. And by the way, just so you know, every not-for-profit hospital, if you ask them for what their prices are, they have to tell you. That's just something. Most people don't ask. but they have to tell you what the price of things are. So that gives you an opportunity to shop if you want to do that. Now, probably no one wants me to tell you that, but that's the truth. So anyhow, this is just a brief thing about pricing. If you want to know the truth, as most people in hospitals have no idea how things are priced. So now you are on par with those people. And if you work in a hospital, now you know something that maybe your coworkers don't. So I hope that this has been instructional. Watch for more videos. Enjoy your day.